next surgeon is Dr. Shishir Agrawal. As we all know, he's from Delhi and Meerut. He will be doing phaco.
Next we have with us Dr. Shishir Agrawal, who is Director Consultant Agrawal Eye Hospitals, Meerut. He's going to be operating a 71-year female who's come with BCVA of both eyes, right more than left, with NS1 cortical PSC for right eye. And the implanted IOL, we've planned for a 20.5 diopter IOL for the right eye for the patient. Over to OT number 1 with Dr. Shishir, please.
Yeah, good morning, everybody.
Yeah, good morning, Dr. Shishir. Yes.
Good morning, please. So we have this 71-year-old female. She has cataract in both the eyes. There's no astigmatism, so we are implanting Rayner's lens, a trifocal lens.
So what is the IOL you are going to implant, Dr. Shishir? Dr. Bhalla Desai.
This is a Rayner trifocal lens, Ray 1 trifocal.
Okay.
Do you have Dr. Ellen Kumaran, Dr. Tagmurthy Sharma sir, or Dr. Krishna Prakash sir here? If they are there, please, you are invited to join the panel. No, this one.
This session only.
So we can see very nicely a 5 to 5.5 millimeter rexis is being done. You can always see that the leading edge of the capsule is flat, and that is one of the pearls that we all must always remember. As it's a trifocal implant, it is very, very crucial to have a perfect rexis.
Beautifully done, Dr. Agrawal. This is Piyush here. And the focus is wonderful. We could see the entire margin of the rexis, a beautiful 5 millimeter round rexis.
Yeah, thank you so much. Yeah, this is a crucial part, a good round and a correctly sized rexis is important. Get it home. Right. Side instrument, please. Side instrument. Chopper. Right foot once again. Yeah. I try to be on the limbus, more on the scleral side, so that there's less of, especially with the main incision, less of astigmatism, SICS. I think. Try to take out the viscoelastic and then inject fluid very gently for a good hydrodissection, not be very forceful. So many times see patients who have a PC rupture at this stage, we should be very gentle. Little more fluid. Methyl cellulose, HPS. Okay. Forceps can you give them? Forceps, corneal forceps. Yeah.
So what are your preferred technique of nucleotomy, Dr. Shishir, in these soft cataracts?
So this is a grade 2 cataract. I would just make a little trench and then chop and then remove the pieces. It is hard enough to make a trench and then crack it.
Very beautiful, sir.
This is a torsional phaco I am using, although this is not a very hard cataract. The chamber stability is very good.
Do you reduce your parameters when you come to the last fragment, or you just manage with
Oh.
your foot switch, sir?
So I manage with foot switch only.
Okay.
Don't change too much of parameters.
Yeah, very nicely demonstrated technique of
The
job.
side port, please.
Yeah.
I just enlarge the side port a little for the bimanual IA to go inside. IA. Yeah. So I've been doing it with this Nidec torsional phaco, and it is pretty good for even for the hard cataracts. Would be using the bimanual IA. Fluid is not there. Being scleral, the minus thing is you tend to get chemosis at times.
I think ideal way of removing, just hold the anterior lip of the cortex and pull it centrally rather than going to the equator or inadvertently catching the posterior lip. So hold the anterior lip of the cortex and just drag it centrally, centripetally, and then have full aspiration and remove the cortex.
Change hands.
So as you can see very beautifully, now there is change of hands and the instruments so that you can go from the opposite side. Especially for our young ophthalmologists, it is very important that you follow all these principles very, very judiciously so that you have a very predictable and safe procedure. Yeah, nice. So now we have this last small cortical piece which is stripped, and now we have that small few fibers. Very nice.
Fluid.
So we could see that it was a softer cataract, and the softer cataracts have their own ways to handle them as compared to the moderate cataracts and of course the hard cataracts. But it was a beautiful demonstration of both nippleotomy, removal of cortex, and now we are going to see the implantation of the trifocal IOL. So can we know more about the lens, Dr. Agrawal, please?
Yeah, so I've been using these Rayner lenses for quite some time. The EDOF, as Dr. Kudlu had just demonstrated, and the trifocals as well. So they are on the diffractive technology and a patented one. So I've seen the rate of PCO is very, very less with these. And I mean, the quality of vision and all the three visions for distance, intermediate, and reading is pretty good. There are some cortical strands in the periphery would remove after the IOL is done. नहीं, forceps से भी. हाँ. Note कर दिया? Note कर दिया lens? ठीक है. So this is the trifocal lens. एक चॉपर और देते हैं क्या एक और चॉपर so it is opened upside down so I'll just flip it which can be done very easily
So I think it was very nicely demonstrated, and for the sake of our delegates, it is very, very important that such maneuver should be done under a great care, and you should be always away from the endothelium. If possible, one can also use a dispersive viscoelastic before flipping the lens.
So, I mean, to flip the lens is quite easy.
Yeah.
I'm never bothered actually if it opens upside down.
Yeah, I think especially in this one, because this is again, I believe, a hydrophilic
Correct.
material,
Correct.
so they are more flexible
Sure.
compared to the hydrophobic
Absolutely.
ones.
That is right.
I think very nicely managed
Yeah.
how to reverse, but the only point of caution is fill your chamber with the dispersive viscoelastic so that endothelium is coated before you undertake such maneuver. Or other thing you can do is, if you find that your lens is opening in a reverse direction, just pronate your hand so that you
Yeah.
can correct that reverse opening there and then. These
Sure,
are some of the few tips which you can
Yes.
undertake.
So I find these to be very good lenses actually, and I mean, I don't have any hesitation in telling this to the patient for this lens because you practically get a 6/6 and 6 vision post-op.
Right.
Very, very nice demonstration. Thank you so much, Dr. Agrawal, sir. I think it was
Thank you so much.
beautifully done
Thank you.
procedure.